Edge of the podium. I have no financial conflict to disclose. Pooled analysis of major randomized control trial comparing asymptomatic patient and endarterectomy with respect to stenting have shown that CAS is associated with a substantially higher per-procedural risk if performed during the first 7 days following the neurological event. And this is also true because in our European Society for Guidelines, they have shown that we have an increased risk when in patients admitted to stenting if this is performed within the first 7 days. So that in guidelines it is suggested that whenever a carotid revascularization is considered in symptomatic patient, it should be a carotid endarterectomy rather than a carotid stenting. But we know that stroke treatment has greatly changed in last years, and mechanical thrombectomy has gained a wide spread into the world everywhere. And we know that tandem occlusion account for 10 to 20% of all large vessel occlusion stroke, that is to say an intracranial lesion is accompanied to an extracranial lesion. So studies have demonstrated that combined synchronous treatment of an intracranial lesion with a stenting of the carotid offers favorable results in respect to delayed stenting of the carotid. So this is what really happening to the world, and different studies also very recently have demonstrated an improvement in functional outcomes in patients with tandem lesion that are treated with a synchronous treatment of intra and extracranial lesion. And we know that we have some advantage of ICA stenting, acute ICA stenting, that is, for example, the recovery of the hemodynamic impairment in those patients. And this is just a case we operated in our hospital of a patient with an one occlusion treated by neuroradiologists, in which we implanted a carotid stenting synchronously, a mesh cover one, in order to trap all the debris from the plaque. American Heart and Stroke Association guidelines say that mechanical thrombectomy can be performed, and among criteria for treatment, there are the occlusion or stenosis, significant stenosis of the internal carotid artery. And they also suggest that treatment of tandem occlusion may be reasonable in those patients. So reality is that urgent carotid stenosis, symptomatic one, is treated by carotid stenting in this world. And also the SVS guidelines suggest that the endovascular treatment might be considered and with acceptable clinical outcomes. We all fear the risk of CAS-related embolism that is maximal when we cross the arch, when position the filter, deploy the stent, post-dilate. But it also continues over time with an idle expansion of the stent. But we know that there are some adjunct key points that we can use nowadays to gain a success in CAS procedure, even in urgent patient, that is to use different access route of stent design or cerebral protection device, for example. The major adjunct in CAS technique that are useful in urgent cases can be considered nowadays the transcervical CAS, the proximal occlusion protection devices, and the use of mesh cover stent. So really, we don't have nowadays just two procedures to consider in those patients, but we have to consider that we can consider this improved procedure to treat urgent patients. And we don't have much data in literature based that accrue for evidence. What we know for TICA has demonstrated also in urgent patients low rates of complication and a low rate of embolism to the brain that is comparable to endarterectomy with respect to what happened in transfemoral convention and CAS. Avoiding the arch and inverting the flow seems to be the way to proceed with stenting in urgent patient, and also the guidelines say that TICA with cerebral flow reversal had the lowest reported stroke rate to date. And also the use of mesh cover stent can be very useful in those very vulnerable and unstable plaque, because they enhance the possibility to trap the plaque, to block the plaque, and prevent debris from migration from embolism to the brain. The study has demonstrated as the second generation stent, that is to say the mesh cover stent as a whole or singularly considered, are lower 30-day and 12-month ipsilateral stroke rate when compared to first generation stent. And when is the best time? We'll know that time is brain. And if we are aware that the reperfusion of brain zone with loss of the regulation can increase the risk of intracerebral hemorrhage, and it is so that European guidelines suggest to wait 6 days after intravenous thrombolysis. We have heard from Professor Venermo that intracerebral hemorrhage occurrence is not strictly time-dependent. To conclude, according to guidelines, a symptomatic carotid plaque should be best treated by endarterectomy, but nevertheless, common practice is that nowadays tandem lesion treated by mechanical thrombectomy and standing, so the standing is used. Increase in endovascular treatment of urgent carotid disease is expected since new technique and devices are available nowadays, and registers on DCCAS and second-generation stent are promising. So a new stroke era has started, so it's time to insist on collaboration with other stroke specialists, especially neuroradiologists, to best treat stroke patients, and I thank you for your attention.